years, but it's okay. We love you anyway.
Okay, thank you.
Yeah.
So Victoria, Carrie has a podcast also, and she has a fancy job with a big group practice, I think. And then, because I don't know, Carrie, anymore where you're working right now, so I'm going to just leave it at that. And this is Rita, who you've heard me talk about already. And
hi, Rita.
Yes. And so hopefully we'll get other people to stumble across us as we talk about thermography.
Mm-hmm.
So we've got there's a couple other people on there, right? That's you. That's Victoria. And Tooth Picker, is that you, Rita?
That's Rita.
Okay. I thought I saw.
So there are other people subscribed, and other people said they would join us, but you know how that goes. All right. So what was I going to say? All right. So here's the thing. The whole idea behind the oral systemic link is this idea of inflammation. And inflammation has a heat signature that we all know about, but never called a heat signature before. We just always called it, oh yeah, it's hot. You have a fever, whatever. And then, and then we just kind of assumed all these things that went along with it. But years ago in the 1950s, there was a development on heat cameras that were able to detect minute changes in surface temperature on the skin. And we are able to take images of that heat now that it's been refined so much further, that we can do more with these cameras than what we can with x-rays, or at least in a different way. So Victoria has been following this oral systemic problem and the dental hygienist with limitations problem for 20 years also. And she has developed something called Strawberry. And I would like for you to talk about that a little bit. And then this idea of thermography for dental hygienists and how they can make a living taking thermal images for head and neck dental patients.
Well, Shirley, as you know, as a hygienist, and we all know, we've seen inflammation in the mouth several times. And even after we have a patient in our chair and they've seen their primary care physician and had a physical exam, we hear everything's fine, everything looked good, and I'm cleared for landing, right? And we get in their mouth and we see the inflammation, and we ask, did the medical doctor look inside your mouth? And 9 out of 9 times they say no. And sometimes they'll say, they'll think about it and think, well, why? Why should the doctor look in my mouth?
Right.
And we know years ago, right, in the 40s, didn't the doctor say, open up wide and stick your tongue out and say, just even look at your throat. And so the system I designed was based around the college degree that we all received through dental hygiene, and based on the guidelines that the ADHA talked about in the assessment of the extraoral and the intraoral exams that dental hygienists are taught to do. And I noticed that when I took the time to do those exams prior to a clinical exam and treatment, I wasn't having enough time, and I was told many times that I needed to stop doing those exams and just roll my sleeves up and just get into the clinical and forget about the what I call right. So the software
is that wrong? Just kidding.
She doesn't know you, Carrie. You're
sorry.
Just what? Well, it's funny that I was just having a conversation with a couple of doctors that I've worked with, and they were wondering about the new payment fee schedule or payment way that they're paying the hygienists at their new practice, and they are now being paid on commission. And they were saying, well, if we've got all this other exam stuff to do, how are the dental hygienists going to feel about that, because we're going to be taking away their productive time? I'm like, they just have to learn how to work better under those conditions. If you've got a kid who is not breathing, that their face is small, that they have black circles under their eyes, they're naughty in school, they're this, they're that, the other thing. The last thing you want to do is finish the appointment. The most important thing you want to do is help figure out what the problem is. And it's the same thing that you're saying, Victoria.
Well, you're right, Shirley. And, you know, as we know, we've been around for a while. I believe with all my heart that dental hygienists are the best screeners on the planet. I think because we've been taught so well to look for things that are problems and record them. And better than the nursing profession, better than, you know, all the other professions out there, medical and dental combined. And there's something about our profession that really, truly gets the oral systemic link inflammation. Everything. We know, especially ones who have been trained to see it. So I took that information that we know from, you know, our education and all our continuing education courses and put it into a software. So the software actually walks you through the steps. And even when I'm shocked to find out that there are dental hygienists that are not educated about the oral systemic link, I guess I was fortunate because I was married to a medical doctor from Europe who said 1 year outside of my dental hygiene training, you cannot fix what you're trying to treat until you treat the whole body and you're looking at oral systemic links. And that was a year right out of hygiene school. And then from then on, I couldn't stop looking at these links and trying to mention it to the doctors and saying, can't we get to the dentist? Can we get them out earlier or tell the patient? And I would upset the patients, or I was told I was upsetting them. So, but the software itself really is bulletproof, because even if the hygienist doesn't have that education, all she has to do is press on the icons, and we're even going to upgrade it even more to make it simpler. I thought it was simple, but now I realize I had too much information in there for them to collect. So I'm going to make it even more streamlined, and it'll be a web-based application. It is web-based halfway now through remote servers, but I'm excited about it because it calculates a wellness score, or if it's now going to be called an oral systemic inflammation score. So this inflammation score, this OSI score, is going to be taken by dental hygienists and a new language. So before surgeries, joint replacements, heart transplants, or any kind of modality with a patient in the dental or medical field, OSI scores are taken by dental hygienists, and not just using a software and a thermal imaging camera, but how about a microscope? And how about some other screening modalities out there? And that's what Shirley comes in. And why not add more? And you talk about commission, why not structure for hygienists to learn how to become business women or men, and structure their whole business around these oral systemic link screenings, and have a whole business in itself. And I have been doing it for quite a few years now. But, you know, there's a big gap between the medical and the dental communities that have no language. They just don't. You have the dental clearance report, and that's it. And that's two questions. Do you have cavities, and is there any gum disease? But that's not enough. Well, we already know. So with this, we need to carve out. we need to carve out our new, you know, and I see this with insurance companies. I just came out of a meeting where it's a wellness prevention insurance company. And they're not going to accept everybody, but it's called ONA. And I'll have to give you the information, but that's why I was a little, you know, trying to get sorted here, you know, I see this prevention movement in the United States. It's been in the world, but the U.S. has been behind. And so I'm ready, excited for us to be a part of this new movement. And kind of how I see it is restructure dental hygiene. I'm sorry, but I can't pick up another hygiene magazine and see another instrument, you know, or another way of, you know, a prophy angle. It's like, no, I can't do it. It's just, there's no challenge there. And these are we're smart women. I come across it, and they're not challenged enough. They're recycled. It's recycled hygiene, you know, and it's not moving forward. It's just keeps recycling, where we can recreate the movement of our profession and bridge that gap between the medical and the dental. And I know I've been kind of off radar for a while, but I haven't been off radar. I mean, I've been working behind the scenes to help make this happen. And I'm really passionate about it because there's so much more we can offer to the communities that we haven't been able to yet. And that's why with the software and having an OSI score and having that thermal, the thermal is the other part of the link because it's a visual image that shows the hot spots and the cold spots. So it really does show right away where that oral systemic link is the root cause, and along with questioning the patient. But that's where the intuitiveness of a dental hygienist and her or his experience comes in, because we know things that are in our experience of working with patients in a chair. There's more than what we're just seeing, and we can dig deeper and put it into our reports for these doctors, and they absolutely love it. Here at the clinic where I work, they get so excited. You know, they know I'm not diagnosing, I'm just giving them more information into a report, and they start to depend on it.
Did you have a question, Carrie?
I just think it's fascinating that we talk about how patients, you know, we're so limited within the time that we can get because of the fee structure and commission based. But when I started bringing in auxiliary things into patients that I could explain the value to and get them to understand the value, they're happy to pay with dollars. But I think it's a really hard thing for hygienists to get over the fact of feeling like they're selling something because they, and maybe it's because they're not really passionate about anything. I don't know what the answer is, but I find that so often they pull back because they feel so constricted, or they don't feel valued by their patients, or they don't feel valued by their doctors. So I think that not only is it a mind shift setting, but it's also learning how to ask the right questions, both from your patients and from your doctors, and really exploring that without feeling so, it's a word that I'm looking for. Sorry, I've been in the hospital for 3 days with my mom, so my head
all
is
these
not with
hospital
me.
terms should be right at the tip of your tongue.
So they just, you know, they're just so, I feel like they're so resistant. And in the offices that I go into, because I help coach in some corporate offices. And that's always what I hear is, I don't want to sell, or I can't, you know, I feel like I'm trying to sell something, or I don't have enough time. And I think it's really easy, like languaging things that hygienists can get behind. And first you have to get excited about it and get passionate about it, and then care to really kind of work on those skills. Because it is learning how to talk to the patient about what's important to them instead of what's important to us. And I think that's what kind of the modality that many hygienists that I run into are kind of stuck in.
Well, you know, I was forced into getting out of hygiene, clinical hygiene, because of my health situation. And I had to recreate myself kind of by default.
Me too.
Would I have, you too, Rita, would I have done that had I not been, would I, you know, taken the route where I could still, you know, stay in the clinical environment and get my paycheck? And what, I know we just lost Carrie, maybe audio only, but what I did notice is that in my interview with hygienists is there are higher and higher percentages that want a change. And that doesn't necessarily mean they want to earn a living inside a clinical environment. They perhaps want to be on their own. And that is a mindset, and it requires even, and Shirley and I talked about this, how to turn a computer on, how to create a new folder on a computer desktop. I did not know that this was going to be something that it was a learning curve. And, you know, here I am in the software industry since the 1970s, and it's just second nature to me, but that's Victoria. I would come home and work on a computer. So that's just me. Right. But I didn't know that, you know, on these mommy breaks, people are working with their children at home, and they're, you know, the last thing they do is get on a computer, maybe email. So to help them make that transition, and Shirley and I've talked about, you know, even teaching so that there is that intermediate before you become your independent, maybe a dental systemic thermographer, or in, you know, putting your screening business or whatever label we want to have. But it's needed for that transition to build confidence. I've seen it, just to build their confidence. And we just had a course here, and we had 3 hygienists, and 3 out of the 3 were technically challenged. But the fun thing about it is, out of the 2 weeks now that they've been on their own, they started to now get more excited. Now they're learning more and getting, the vibration of, I don't know this, is challenging for them. And so now they're getting on the computer longer and they're staying on it. And I'm seeing it was at first a little like, how can I say this? They were unsettled by it because they weren't expecting that. I think they were expecting just to come and learn and how to click a camera and then go home. And then I was teaching, no, there's a lot more. Do you have a business name set out? Have you thought about networking? Have you thought about, okay, let's get on the computer and get on it. And so there was quite a bit of learning curve for myself because I assumed that they knew already a lot of 2016 technical things, and they, a lot of people are working off their phone. And maybe an iPad will be the future where it's going to be, take an image with the thermal camera inside your iPad. I mean, the future is it's just so exciting. I mean, they have a cell phone thermal imaging attachment to your cell phone now. You have one?
For the, I looked at the apps and I saw that is it Flix or
it's Clear, and yes, and consumers ordered so many that they're 10 weeks behind on back order. They didn't expect it. FLIR did not. And for a company like that, of that billion-dollar company, to have a back order of 10 weeks tells you it was in the millions. They got backlogged order. Consumers are interested in this. And so really it's, and really I even say to the hygienist, I say, don't just stop with humans. If you want to expand your oral systemic, go into the veterinarian or go to your animals. And I mean, it's not, people, their pets are like their family members. And so really there's just a lot more avenues to explore and not be, limited. I think in hygiene, we've said, gosh, if we injured ourselves, we would be limited. Now we're not. Take that cap off, like what Shirley's doing is awesome. And we don't have any limitations. It's just, it'll keep growing. And then we work in tandem in partnership with the medical and dental communities and not have that, lack of confidence that he was talking about earlier, that the hygienists don't want to sell. Well, I wouldn't either if I was promoting somebody else's business and I had to do everything for them. And I just wouldn't.
Nobody ever talks about that part of it. That's hilarious.
I actually,
we're really taught that dentistry is necessary when oral hygiene fails. So, or when dental hygiene fails. So really we're admitting to failure if the patient has to have any dentistry done. So maybe that's a little secret, little twist in the head too, that we have to kind of work with.
I don't know, but I know this, it's definitely, it's working under the thumb, So, and then you don't even factor in the front office and the administration part, and the pressures that we have at front office, and then if you have the back office and they're not on board with you, then you've got that pressure. So you're really kind of by yourself, and that's what happens to a lot of hygienists. When they say, I don't have any time, what I hear is, I don't want to make the time because I don't have the support. So what's the point? That's what I saw a lot. How many times did you try to get someone to help you perio chart? And once a year,
And act as though that's the most important thing out of everything that we do during the appointment. But yet, very often or too often, things like the oral cancer screening get skipped in order to get those measurements done.
Absolutely right. It's, and this is what was just so unsettling with me all these years when we were taught to do all that screening and it was skipped. And it was life-saving, I mean, we could literally pick up nodules in the neck. I mean, we saw so many things and it was overlooked. And so someone would come into our room and being the dentist and sit down and what's the next thing, and what do we find? Or they would be taken out of our environment and put into that, and in our notes weren't looked at, or if they were looked at, it was only drill, fill, bill. And so the mentality, and I think my frustration has been that for all those years.
So tell a little bit about the thermography in general. We don't have the ability to like share a screen or anything like that here. So for people who want or who are interested in learning more about it, they can, you know, go and just type in thermography and come up with some of the images. So what does it do exactly, and what's the benefit of having it done if you're a patient? And why should dental hygienists do it and not just Joe?
I'll tell you why. Well, okay, let me back up.
Good.
And this is thanks for all the questions.
How many questions were there? I don't know.
Yeah, go through them. Okay. Thermography in general has a certification level, different levels. In level 1, you have clinical thermography. And clinical thermography is just becoming a technician, taking the images, and you're taught to take images on the entire body. You're a technician and you're taught to image. There are companies out there that teach their way of doing clinical thermography. And they really teach you maybe the patterns and the positions of the person to take. I'd say about 100% of the time, except for just recently, one company just created some new guidelines. They would teach the positions of the head and neck, but not go into the correlation between the head and neck and the rest of the body. So if they were teaching breast imaging, they would cut the image off just below the neckline or right above the breast, and not get that oral systemic condition, or image in a thermography that would show maybe a tooth leaking down into the lymphatic, through the lymphatic into breast tissue because of a leaky root canal. Now, if they just were doing breast imaging, and most people just want to know, are my breasts going to be cancerous or not, then they would skip that part in their clinical exams, or not clinical, their exams with their doctors, and the technicians would just take that part. Then next year they would come through next year, and then there would be, something happening, and they might have to cut the breast off instead of tracing out to the root cause. So thermal imaging with a dental hygienist, we would, just like today, I was approached by a medical doctor that one of his patients has a lump just above her left breast. But it's almost like right below her collarbone. And I said, well, the best thing to do is back out of it. And as she goes through the questioning part, we'll take the images of the head and neck area, include the breast down to the stomach. So the doctors can see a 360 view of what is going on with her. And my reporting would be in questioning through the software where, if she's had any oral systemic conditions that would be related. So a dental hygienist doing the thermal imaging would be very conscientious of putting this all together versus just imaging the breast for the doctor, and taught to look at the oral systemic first thing. That would be right out of her mindset, is the first thing is to do a oral systemic scan. And the thermal imaging, there's a lot of physics behind the sensors and the camera, and there's different cameras. And you could purchase a camera through a company and not go through these other courses like I was talking about to be educated. They would train you how to use that camera, but they wouldn't train you how to take images on a patient. So now you have to marry both of them. And the ones that teach you how to take the images on a patient don't really teach you about how to use the equipment. So you're kind of...
So you need two teachers.
Well, both organizations think they're doing the right thing, but you're kind of stuck. And I saw the need to have both taught. So that's why we have hands-on for 2 days. You hold the camera, you turn it on and off, you take the images, you write the reports, you do the imitation visits, versus sit there and listen to someone tell you, okay, the person does this, and it's very different. I thought, just like in clinical hygiene, we were taught, pick up, start working. And that's how we are. We like to work with our hands. So the thermal imaging, you'll be able to focus on the patient areas, and even the camera has software that you can point and locate measurements, heat measurements, and put a spot on that image for the doctor to take a look at, just like we do in perio charting. So it's like spot probing, but you're spot probing with images, with hot spots,
with the camera,
they call them.
yeah.
Or cold
so
spots.
they do call them hot spots. Yeah, right. Okay.
Yeah, there's hot spots and cold spots. And you as a hygienist working, it's probing. It's literally probing. And I have this one quote that says, probing doesn't always mean, in the mouth. So you're probing for those, problems in those areas. And what I can only imagine the stories we'll receive over the years as hygienists start picking all these things up, because who knows where we're going to find it, and where it's going to originate.
It's really important to have these kinds of things, because what I'm seeing, exactly what you're seeing, is that when we graduated in the 80s, the lifespan of a dental hygienist was about 8 years, but now it's like 20 or 30 years. There are people in my graduating class, Rita and I, that are still clinical, and they're holding seats for new graduates. And they've already practiced, they're already good at it, and they don't know what else to do, because we have such a thick glass ceiling in clinical dental hygiene. And now that some of these things like oral facial myofunctional therapy and imaging and I don't know, there's a few other things that we can do on the outside, speaking and writing and actual selling. So all of those things are available to us as hygienists. And it doesn't, I almost said as, ancient hygienists, but that's not true. This is kind of stuff that you'd want to know about right out of school. There are hygienists whose hands burn out after a year or two, and or their neck blows out or something like that, and they can't go on anymore. So I think it's real important to have and to make these kind of new things known.
Oh, there's no question about it. And I've always been an advocate of growth and, creating and expanding our knowledge. And, take, for example, the nursing field. They burn out in one area, they can go into another area, or they can keep going into different categories, if you will. Where do we go? I mean, we had the list on the ADHA.org site, and the list was I guess we would fit into was entrepreneur. But the others was sales and research, and that doesn't. There's so many hygienists they want to still have that patient contact and work in some kind of environment where they're helping to produce something and health and guide. And this is the answer. I know thermography and what you're doing, Shirley, and providing with your myofacial, and that's just the tip of the iceberg. I think there's going to be a lot more than what we even see now. But using thermography as the gateway to have a starting point to say, now we see this hot spot, let's look over here now, and then you get to the next, and that just kind of a chain of cycling of or events to screen. So there's
do you have any questions, Rita? Oh, she's on mute. We didn't hear a word you said.
we saw the lips moving.
We're moving. Her heart was in it. I don't know, a little couple of laughs there. But all right, so your next class, though, is coming up in March. Is that still your tentative date?
No, yes, March 11th and 12th. Uh-huh.
Okay. And then your website is back up, thankfully?
Yes. We love hackers.
No, we don't. We love them to death.
No. Yeah, to death.
All right, so right. March 11th and 12th, and they can sign up on your website, and your website is Thermalinx, right?
Yes.
Therma, THERMA.
LINX. And what I've done and what we've decided to do, instead of paying it all up front, they can pay for the online course, and then when they're ready to take the on-site course in March, They can take it, or they can skip that time if they can't make it, and then take it when we'll have it the following month, an on-site course. So the online portion is really at their discretion when to take it, as long as they take it within about 8 to 10 days before the on-site. So you look confused. Confuse you?
No. I'm like, okay, so they can take the online portion starting tomorrow and finish it, but don't take the test until the week before the.
Well, no, they'll have a quiz. They'll have a quiz after each section, but to take the hands-on is here in Las Vegas, will be in March. So
okay, but how do they go together? The online part and the in-person.
Well.
Part?
That's a great question. When
timing wise,
you mean as far as
you said something about 8 days, and I'm trying to figure out where that came from.
You want to take the information to get the online course completed before you come to the on-site. That's all.
Oh, I see. Okay,
have it completed, because what I discovered, and you too, is that the more prepared you are in what you're about to educate you, the less time it takes, and we can just get right down to business and start imaging. So that's what the goal is get your reporting taught, and instead of all the other hiccups of what is thermography and why is it important. That's all online. Take all that.
Okay. Excellent. Okay, great. So is there anything else you wanted to make sure to say before we say goodnight?
Other than it was a pleasure. I'm looking forward to this movement of new dental hygiene. I would like us to come up with a new term for it. I have my term, but I think there's a whole nother world out. I call it non-clinical dental hygiene. I guess that's what I've been calling, so that we can work in an environment, maybe in a chiropractor office, or maybe out of a naturopath office or holistic medical doctor, just to get the options for us, so we're not thinking we always have to be inside an operatory, that we can be elsewhere and earn a nice living. So, but no, I'm
all for a nice living.
Yes, we all for it.
Well, this was fun, and thank you so much for joining us again today. And sorry you had to set up a Twitter account first.
Now I can Twitter, so okay.
Tweet. I guess I didn't know there were so many hurdles. There's just really no good communication tool. They all have hiccups.
I was, I knew I had to do that, and that was years ago, and I got lazy. But you're right. I mean, don't assume. I assume too all the time with my. So. Well,
Rita had to download Chrome. I mean, it wasn't even going to work without Chrome on her whatever gadget she's using there.
I had to do Chrome and Blab. So
yeah.
So you had to do both. Oh wow.
Yeah.
So Rita, I hear you now.
Yay. I unmuted myself. I have birds and they're quite noisy, so I didn't want to have them throughout the whole conversation.
Squawk, squawk.
Yeah. Are you in Wisconsin as well?
Yes.
Oh, okay.
Yeah, we're a long way from the heat in Lost Wages, that's for sure. All right. Well, have a good rest of the night, everybody, and we'll see you soon.
Okay. Good night.
Bye.
Bye.
Bye-bye.